Hello and good evening, dear doctors. So I'm just continuing the second part of the OSCE from radiological diagnostic. So let's continue. This is number 10. So look at the question here. The question is, what are the radiological investigation? What radiological investigation is this? Okay. So see here, how do you recognize this? So there is a catheter which is inserted. You can see here there is a catheter which is inserted. Okay, here it is not nicely seen, but here also it is seen here. Okay, and they have injected the dye. So this is a radio contrast material or the dye, and this dye has passed up to the ureter and it has reached the pelvic calyceal system or in the kidney. Okay, and you can clearly see the ureter is dilated, the pelvic calyceal systems are dilated in the kidney, so we call it hydroureter and hydronephrosis. So this is called hydroureter. Okay, and this is known as hydronephrosis. Now this is possible only if there is vesicoureteral reflux in this area, VUR in this area. VUR means there is a reflux between bladder and the ureter. Remember, normally there should not be any urine going up into the ureter. Okay, when there is a reflux formation or development, then only urine can go upward, and this is a very pathological condition, because if the urine is infected in the urinary bladder, that infected urine can easily go up into the ureter and can even reach the kidney. So it can cause urinary tract infection, that is called pyelonephritis in the kidney. Okay, so this is a very important knowledge. Now see here, the second picture is showing bilateral involvement on both sides. So there is bilateral VUR, and the third one is also the same thing. Okay, so findings you can nicely write now: unilateral and bilateral involvement of the ureter and the kidney. And what are the indications for this test? So some of the common indications for this test would be, okay, number one is urinary tract infection in children. Okay, urinary tract infection in children, especially the repeated UTI. We love to do, whether we have to rule out the vesicoureteral reflux, and for that the MCUG is the best type of test. So the name of this test is called MCUG. Okay, micturating cystourethropography, MCUG, or VCUG. M for micturating, V for voiding. So I'll write it here, the name of the investigation: MCUG or VCUG. M for micturating cystourethropography, and V is for voiding. Okay, voiding cystourethropography. Now how this test is done, few lines regarding this. First we'll put a catheter into the urinary bladder, then the dye is injected, and after that fluoroscopy is taken, right, and ask the child to void the urine, child or adult, whoever you are doing it, void the urine. And during that time the X-ray is taken. And when voiding the urine, what happens to the urinary bladder? The pressure is high, and if the dye is going up into the ureter, okay, that's what you want to see for the diagnosis of VUR. Okay, and one more indication for this MCUG would be posterior urethral valve suspicion in the child. Okay, that we'll talk in our next case. Okay, I've included a case of posterior urethral valve also here. So let's move further. Now another case, okay, just pay attention here. What is the diagnosis and write to complication. Look at this gross specimen. This clearly looks like polycystic kidney. polycystic kidney. Okay, and this is ultrasonography. Okay, this ultrasonography is showing the multiple cysts in the kidney. Okay, like here is the one, here is another one, multiple. Okay, multiple cysts in the kidney. So this is called polycystic kidney disease. Now a little bit of information regarding polycystic kidney disease. What type of condition is this? Now polycystic kidney disease is of two type. Okay, adult polycystic, okay, adult polycystic kidney disease. So we call it, actually, what is a term we use for this? Okay, see here, autosomal dominant polycystic kidney disease. It is adult type, and autosomal recessive polycystic kidney disease. This is the infantile type. Okay, infantile type, or which occurs in a child. Now let's highlight some of the very important point here. Okay, not in detail though, but some of the important points here. So what is the important things here? Number one is both of these are genetic condition, or they are hereditary condition, I should say. So the hereditary status is written here. One is autosomal dominant, another is autosomal recessive. So the affected genes are polycystic kidney disease 1 gene and polycystic kidney disease 2 gene, and they are encoding the polycystin protein, okay, 1, and polycystin protein 2. If they are abnormal, then there can be polycystic kidney disease, the adult type. Whereas in case of autosomal recessive or infantile type, okay, there is polycystic kidney and hepatic, right? Hepatic disease 1 gene which is affected. Okay, so this is polycystic kidney and liver disease or hepatic disease 1 gene which is affected, and it will encode fibrocystin protein. So this fibrocystin is abnormal here. This is the basic thing. Now what will happen to the patient? Okay, in case of adult onset polycystic kidney disease, the hypertension and the clinical manifestations, the other clinical manifestations, they occur very late. They occur usually after 40 to 50 years of age. Okay, 40 to 50 years of age. Till that time, the number of nephrons may be enough for the function of the kidney. That's why it presents very late. Whereas in autosomal recessive polycystic kidney disease, it manifests quite early. It manifests quite early, and usually these cysts are developed from the collecting tubules here. Okay, in the autosomal recessive type. This is also one important question they love to ask. So it manifests quite early, usually in the infantile period or early childhood, and this is a serious condition. There may be death quite early in the life. Okay, so these are some of the very important point here. Nowadays, students, what is the other question here? Write 2 complications of this condition. It looks like adult onset polycystic kidney disease. So the 2 complications of this you can highlight is there will be hypertension. Okay, then there is a high chance of occurrence of liver cyst or pancreatic cyst, or the berry aneurysm inside the brain. So I like to highlight this with the help of this another slide. So please pay attention here. So there is a high chance of cyst formation in the liver and in the pancreas. There is high chance of berry aneurysm. This is an extremely important question, and this berry aneurysm may rupture, and you all know when they are ruptured, there will be subarachnoid hemorrhage. Okay, and subarachnoid hemorrhage is defined as, or how the patient present to the hospital. If they are conscious, they say, this is the worst headache of my life. I've never felt this type of headache before. Okay, but in the majority of the case, they are already unconscious. Mitral valve prolapse, which is called MVP. Okay, hypertension we already talked about, and azotemia. Azotemia means increased blood urea nitrogen and serum creatinine. Okay, so this is also quite common in this case. Okay, so these are some of the important questions here. Okay, let's move further. Another case, look at this. Describe the findings of this radiological investigation. The first, we should understand or identify what type of radiological investigation is this. So see here, there is a catheter which is inserted again. Okay, this is urethra, and this urethra is dilated urethra. Okay, and this is a urinary bladder. So this urethra is dilated from this area upward. Okay, this is the neck of the urinary bladder. So this is, MCUG again, or VCUG. MCUG or VCUG means micturating cystourethrogram or voiding cystourethrogram, and this is the case of posterior urethral valve, PUV. Okay, so how I recognize this as a PUV? Because of this dilated, urethra. Okay, this is dilated urethra. Now posterior urethral valve, occurs in a male child. It occurs in male child because male child or male has got three parts in the urethra: prostatic urethra, membranous urethra, and spongy or penile urethra. And usually it affects the prostatic part of the urethra near the verumontanum. Verumontanum is one of the structures there, we all know. So there occurs the flap of the tissues, as a result of some developmental anomaly, and this flap of the tissues constitute the posterior urethral valve. Now what is the problem with them? What is the problem with them? I want to discuss a little bit here. PUV. The problem with them is they act like a valve, and valve is always one-way flow. One-way flow. So what is that means? That means the urinary flow is obstructed. Now sometimes, there is so much obstruction, so tight obstruction, that before the birth itself, we can find out, with the help of ultrasound, of course, we can find out the distended urinary bladder as well as hydroureter and hydronephrosis. Hydroureter and hydronephrosis, and this occurs usually on the bilateral, on the both side. So even before the birth of the baby, we can sometimes diagnose it, posterior valve, if it is very severe one. If not, then it can be diagnosed after the birth. One of the important manifestation of this, because of all this obstruction, there will be decreased amniotic fluid, because fetal urine is one of the very important component of the amniotic fluid. As a result of that, this is known as oligohydramnios, and this oligohydramnios will cause decreased expansion of the lung, which will lead to decreased pulmonary development. You understand? Decreased pulmonary development. And as a result of that, there will be hypoplasia of the lung. This is called hypoplasia of the lung, by the way, and this hypoplasia will result in difficulty to breathe, difficulty in breathing. So this is a very important point, and a lot of the babies, they die because of this inability to breathe actually after the birth. They of course will lead to renal failure. This is called post-renal failure. So what type of kidney failure it is called? Post-renal failure. So they may die because of post-renal failure, but more importantly, they can die because of difficulty in breathing in case of very serious situation. And one more thing which is commonly asked in the exam, after the birth of the baby, you can palpate three masses in the abdomen. Three masses in abdomen. The three masses in the abdomen means what? One mass comprises of urinary bladder, and two masses comprises of two kidneys on either side. Because of hydronephrosis, both kidneys are enlarged, and urinary bladder is enlarged as a result of increased urine collection there. and the surgery is very straightforward here. You need to destroy those flap of the tissue. Okay, surgery has to be done quite early. So let's move further. We have discussed a lot regarding this. Now, few of the cases from musculoskeletal system. So what type of case are here? Okay, look at very carefully. This is a clavicle bone which is fractured here. So this is the lateral fragment, and this is the medial fragment. Okay, and here is the fracture of the clavicle. So diagnosis is straightforward. Okay, and what are the complication? The complication can occur is usually non-union of the fracture is one of them. This is a general type of discussion actually, but which structures are very nearby to the fracture, like brachial plexus and subclavian vessels. So there may be injured or damaged because of this fracture. This is quite easy to say, especially if the fracture is a bit of towards the medial side, there will be more chance of the injury. Okay, and treatment is the figure of 8 bandage or sometimes even the surgical fusion. Now let's move to the other case. Okay, look at this X-ray. What is the diagnosis and right to complication? These are the question. What is the diagnosis? This is the hip joint. Okay, hip joint. You can clearly see here. This is head of the femur. Okay, this is called acetabulum. We all know that acetabulum, and this is the neck of the femur. Okay, this is called greater trochanter, and here is the lesser trochanter. Okay, greater trochanter, and this is what? Lesser trochanter. So this is a bit of anatomy. Okay, now look at very carefully. There is a fracture in the neck of the femur, very clear cut case. So this is called fracture of neck of the femur. This is one of the important question from the orthopedics. Okay, so we are doing a bit of radiological discussion now. So of course musculoskeletal system radiology is an important part of that. That's why we are talking here. Okay, now right to complication of this. One of the most important complication of the fractured neck of the femur is non-union. Okay, non-union, and another one is called avascular necrosis. Avascular necrosis of head of the femur. Because of this fracture, the blood supply of the head of the femur may be decreased or lost. As a result of that, there may be avascular necrosis of the head of the femur. Okay, so these are very, very important complication. The third complication, as a result of this, there may be osteoarthritis of hip joint. Okay, try to memorize this. Let's move on. Now, another case, okay, number 15. Now here, this is a 3-month-old baby who was brought to the hospital with difficulty in feeding, very faster breathing and excessive sweating during breastfeeding. This is a typical history given by the mother. Look at the age of the child, 3-month-old. So there is difficulty in feeding, means difficulty in breastfeeding, faster breathing and excessive sweating. This faster breathing may be because of the pneumonia, and in that case there will be fever, of course, but it may be because of heart failure. Okay, on examination there is no cyanosis, so this is not a cyanotic heart disease, and there is a pan-systolic murmur at the left lower sternal border, which is called tricuspid area. Now if I get this much clue, the diagnosis is very straightforward. This is the most common type of congenital heart disease. Okay, not cyanotic, because there is no cyanosis, of course. So the most common type of congenital heart disease, and that is ventricular septal defect or VSD. Straightforward. Why? What's the reason you have here? The typical presentation, difficulty in feeding, faster breathing or excessive sweating. This occurs because of congestive heart failure, and VSD is one of the common cause of congestive heart failure in the babies. And another one is because of pansystolic murmur at left lower sternal border, which is a hallmark of the VSD. Okay. Now, what are the findings on X-ray? That's the question they have asked. So the findings on the X-ray is, this X-ray is having cardiomegaly. Now, as a undergraduate student, if your teacher asks or if your professor asks, how do you know this heart looks big? You can casually say it looks bigger, but usually they want you to answer in other way. They want you, in case of cardiothoracic ratio, if it is more than 55% or 0.55, then it is a bigger heart. Okay, so how do you know that? So it is by the measurement. So of course, see here, the farthest point from the midline, okay, you note it, and here is the farthest point probably. So let's say this is A and this is B. So when I add A and B, it will become C. C means cardiac diameter. Okay, and another is called thoracic diameter. Okay, so I'll measure the thoracic diameter, which is T, and C to T ratio, this is called CT ratio. If it is more than 0.55, or we call it 55%, then it is called cardiomegaly. Cardiomegaly. So this X-ray is having cardiomegaly. There's no doubt. This is having cardiomegaly. Okay, and VSD is one of the heart disease which causes cardiomegaly. That is one finding in the X-ray. The another finding in the X-ray is, look at the lung fields. Okay, this lung field have increased bronchovascular marking. Increased bronchovascular marking. So what do you mean by that? That means there is increased blood flow to the lung. Okay, increased blood flow to the lungs. You understand? So increased blood flow to the lung is called pulmonary plethora. Pulmonary plethora. This is the important point. Okay. Now the most likely diagnosis, of course, is VSD. VSD. Okay. Now one common question which will be asked to you here is this: why VSD takes a little bit time to manifest? Why doesn't it manifest quite early after the birth? The answer is, during the intrauterine life, the pressure inside the pulmonary vasculature is very high. Okay, and it takes time for that pressure to drop, and usually it takes around 6 to 8 weeks for the pressure to drop, and that's when the left to right shunt will establish. Now I want to discuss this with the help of this picture here. See this? This is the picture of VSD, and here you can see left ventricle, and here is right ventricle, and this is VSD. Okay, so this is left to right shunt, and this left to right shunt occurs when there is a pressure difference between left side of the heart and right side of the heart. For that, the right sided pressure should fall, then only the blood start to flow. Okay, so it takes time. It takes around 6 to 8 weeks, okay, to manifest. So this is another important knowledge regarding VSD. Okay, let's move on. Now question number 16, what is the diagnosis and what are the complications? How will you treat it? So these are the questions. The diagnosis is very straightforward. This is the femur bone. So this is a fracture of the shaft of the femur. Fracture shaft of the femur. Okay, and what type of fracture is this? It almost looks like a little bit of oblique type of fracture to me. Okay, not transverse, a little bit oblique type of fracture. What are the complications? Okay, the complication can again be delayed union, non-union, okay, malunion. These are very routine. Okay, routine complications of the fracture. It's quite you can tell to any fracture, and some other complication would be compound fracture, when there is serious injury to the overlying structures like the muscles of the skin and the bone is visible from outside. Infection, okay, there's another, and lots of bleeding. So all those complications you can write here. Okay, And how will you treat it? Usually we go for the surgical management here, that is called open reduction and internal fixation, ORIF, and that can be done with the help of intramedullary nailing, okay, intramedullary nailing, or plate with screws. Those type of answers you can give here. Okay, so this is fracture shaft of the femur. Now another interesting case in case of pediatrics is here. So what are the findings in this picture? The first one, okay, let's say this is A and this is B. Okay, in A, what can you see here? Okay, look here, the legs, okay, are bent. Okay, they are bent and they are coming closer to each other. In other words, knees are going away from each other. Okay, so these are called bow legs. Bow legs, because legs are bent, looks like a bow. Okay, so bow legs. And the same patient, the x-ray is shown here. So again, these are bent, are coming towards the midline. Okay, and this is a typical case of rickets. Okay, in rickets in children, the bones appears like this because they are very softer. They become fragile, softer rather than fragile. Fragile is the term we use if the bone breaks. They are more softer, so they can bend very easily. Okay, so many other features in rickets occur. We'll talk in some other slides. I think I've included one more x-ray of rickets there, and I'll nicely explain everything there. Okay, so this is bow leg in rickets. Now, another related point here, dear student, if the knees are coming closer to each other, listen carefully. If the knees come closer to each other and legs go away from each other, then we call it knock knee. Okay, knock knees. Okay, let me correct the spelling here. Knock knees means the knees are coming closer to each other. Okay, and in medical term, this condition is known as genu varum. Genu varum, and this condition is known as genu valgum. Okay, genu valgus. Valgus means the leg are going away from each other. Varus means they are coming closer to each other. Okay, these are very important clinical terms, and genu is the term we use for the knee joint. Okay, now let's move on. Now that's what I was talking just now. I've included another x-ray of the rickets. Now I can talk a little bit more here. Now what is the diagnosis? If they ask you straightforward, look at what are the changes occurring in the bone. The first is, okay, it looks wider. Look at this whole area. The end of the bone looks wide. Okay, this is called widening of end of the bone, or widening of metaphysis or epiphysis, you can say. Number two is fraying. Fraying means it looks like fragmented. Fraying means it looks fragmented. Fragmented means broken. Okay, looks like that. Third is called cupping. So this is cupping. Okay, cupping, you can clearly see it's going downward. And another is splaying. Okay, splaying. Splaying means it is going away from each other. Away from each other. Okay, splaying. If these are the things given, and it is a wrist joint, of course. This is a wrist joint, which is most commonly examined joint in case of rickets, and second is knee joint, of course. So this is a case of rickets. Okay, no doubt about it. And rickets occur because of vitamin D deficiency. So what are the other features of the rickets? Okay, what are the other features of the rickets? So let's list a few of them there. Okay, other features of rickets, the favorite question by the examiner in any exam. Now, rickets occur as a result of vitamin D deficiency in children. That's the first thing. And the function of vitamin D, we all know vitamin D increases the level of calcium and phosphate in the blood, so that those calcium and phosphate can be deposited in the bone. Okay, so when vitamin D is deficient, that function cannot happen. As a result of this, the bone becomes weaker. This is the mechanism. Now, second is, in the skull, there will be craniotabes, it's very soft skull. Okay, soft skull. Then there will be frontal bossing. Frontal bossing. This is the prominence of the forehead, frontal bossing. Another important feature means delayed closure of anterior fontanelle, or sometimes the anterior fontanelle may be wider than the normal. Okay, or wider than normal. Remember this. Okay, this is an important point. And what is the normal time for the closure of anterior fontanelle? It is 18 months. This is the average one, but you can say up to 2 years also, but 18 months is a good answer here. So if it takes longer than 18 months or maybe longer than 2 years, this definitely delays closure of the anterior fontanelle. Now, another is, okay, wide wrist or ankles or knees. We already talked about that. Another one is rickety rosary. Okay, rickety or rachitic rosary. What do we mean by that? This is prominent and rounded. Okay, costochondral junction. Costochondral junctions. It is prominent and it is rounded. Okay, it is not painful, and when we feel it, it feels rounded one. Now, why this is an important one? Because there is another disease, okay, which is called scurvy. Scurvy occurs because of vitamin C deficiency, and as a result of this, the costochondral junctions are enlarged again, but they are pointed. They are pointed and they are painful. So this is a very important differentiation between these two. So try to memorize it. Okay. Now another important point in rickets is Harrison's sulcus. Harrison's sulcus. So this is a groove formation. Okay, groove formation at the diaphragm area. At the diaphragm area. This is also important point. And another is, okay, deformities of the bone. Deformities of bone, and one of the important example we already seen in the previous slide, that is genu varum and genu valgum. Genu varum and genu valgum. Varum means bow leg, valgum means knock knees. Okay, and then multiple fractures. Multiple fractures can also be occurred. If you know this much information, most of the questions are covered from here. Okay, now let's move on. Another is, see here, this is a case of scurvy. Scurvy. In scurvy, these are typical findings. There will be subperiosteal hemorrhage because scurvy occurs because of vitamin C deficiency. Vitamin C deficiency, and vitamin C is very much necessary for the synthesis of collagen. Okay, so there is decreased collagen or inadequate collagen formation. As a result of that, there will be subperiosteal hemorrhage, which it results in very painful lesion or condition there. There will be scorbutic zone or tremor-filled zone, we say. Okay, there will be white line of Frankel. The epiphysis will become circular or ring-shaped. Pelton's spur. A lot of findings are there in case of scurvy. So what are the other features of scurvy? There will be bleeding manifestation. Bleeding. Okay, especially gum bleeding is one of the important features of scurvy. Gum bleeding. Okay, don't forget that. Okay, there may be hemarthrosis. Okay, because of the blood collection inside the joint or around the joint as a result of subperiosteal hemorrhage. You already know about that. Okay, and another feature may be there will be bleeding around the hair follicle. Okay, the hair will be a little bit they are not easily bent. They become very rough. Okay, that type of feature may also be there. Now let's move on. Okay, let's make this as the last case, and I'll again discuss some more. Otherwise the video will be very long. So this is a straightforward case. Okay, look at here. Just one glance or one view will give you the diagnosis. This is called snowman appearance. Snowman appearance, also known as figure of 8 appearance. Figure of 8 appearance. Now we can clearly see here. Okay, what is this figure of 8? Just follow this. Here, this figure of 8. Okay, figure of 8 appearance. I'll delete it because otherwise it will disturb you later on. Okay, figure of 8 appearance. Now if they only give you this much clue, you can straightforward make a diagnosis. This is a case of total anomalous pulmonary venous return, or total anomalous pulmonary venous circulation or connection. Okay, in short form we call it TAPVR or TAPVC. Now a little bit of explanation regarding this, because you want to know this. This is a type of cyanotic congenital heart disease. Now why it is cyanotic heart disease? The reason is very simple. Just analyze this. This is completely anomalous pulmonary venous return. That means normally the pulmonary vein drain the oxygenated blood from the lung to the left atrium. But here, as a result of some anomalous circulation, they drain towards the right atrium. Okay, ultimately all the blood will go to the right atrium, and there is mixing of oxygenated and deoxygenated blood. That's why this is a cyanotic congenital heart disease. Okay, so this much information may be enough here. This is a very important question. So dear student, so let me stop here for the time being. Okay, and I'll continue to make this type of video, and next time I'll continue the continuation of this. Okay, so thank you.